Alright, this is a mini-med lecture that will cover the medical condition known as mastoiditis. I'll include a detailed description of some basic anatomy, pathophysiology, the clinical presentation usually seen with mastoiditis, some diagnostic techniques, and the treatment details. Okay, let's dive right in. So to understand mastoiditis, we first need to understand the anatomy of the ear and the location of the various structures. The external portion of the ear is called the pinna. Sound waves from our environment travel towards our inner ear via the ear canal, also called the external auditory canal. The sound waves then reach the tympanic membrane, commonly referred to as the eardrum. The region between the pinna and the tympanic membrane is known as the external ear. Deep to the tympanic membrane resides the auditory ossicles. There are 3 tiny bones here which assist with converting vibrations caused by the sound waves hitting the tympanic membrane into mechanical energy. The deepest of the ossicles directs the mechanical energy into a structure known as the cochlea. The region between the tympanic membrane and the cochlea is known as the middle ear. The cochlea is full of fluid, and when the mechanical energy from the stapes enters the cochlea, this creates a wave in the fluid that eventually reaches microscopic structures known as hair cells. These hair cells transduce the mechanical energy from the wave into an electrical signal in the nerve cells. These specific nerve cells make up part of the 8th cranial nerve, and the electrical energy received through the hair cells in the cochlea is transmitted into the brain, thereby producing the sensation of sound. The cochlea is paired up with a structure called the vestibule, which is involved with the perception of position in space and movement. These 2 structures make up the region known as the inner ear. As you can see right here, this is the area called the eustachian tube. This structure is very important and connects the middle ear to the nasopharynx. The nasopharynx is an air-filled cavity deep inside your nose. This tube is important because it relieves pressure and drains fluid from the middle ear. This tube plays an important role when you're quickly changing altitudes, such as flying on an airplane or driving down a large mountain. If something causes the eustachian tube to become blocked, such as inflammation that can occur with the common cold or allergies, this allows pressure or fluid to build up inside the middle ear. If the eustachian tube is unable to perform its function, bacteria may take advantage of this opportunity and multiply within the middle ear. An infection of the middle ear is called an acute otitis media. Now, an acute otitis media is the main precursor for mastoiditis. In rare situations, other conditions can lead to mastoiditis, but the large majority of mastoiditis cases present as a complication of untreated or undertreated acute otitis media. While most cases of acute otitis media occur in children, it can occur at any age. An individual with acute otitis media may present with symptoms of ear pain, ear pressure, decreased hearing in the affected ear, and possibly a fever. To diagnose acute otitis media, a clinician can attempt to visualize the tympanic membrane, or the eardrum, with an otoscope. The picture on the left is a normal, healthy tympanic membrane, characterized by its shiny, gray, and translucent appearance. The picture on the right is a good example of an acute otitis media, characterized by inflammation, erythema, decreased translucency of the membrane, and evidence of pus or fluid behind the membrane. In many cases, the tympanic membrane will actually bulge outward, as is the case with this picture here. Now, clinically significant acute otitis media is commonly treated with antibiotics and antipyretics. Amoxicillin is considered the first-line therapy. If left untreated for several days or even weeks, the purulent infection may spread to the mastoid air cells, which are located in the mastoid region of the temporal bone of the skull. So by definition, mastoiditis is an infection and inflammation of the mastoid air cells of the temporal bone. The mastoid air cells are located deep to the mastoid process, just posterior to the pinna, as you can see right here. The patients with mastoiditis will present with a constellation of classic signs and symptoms. Usually they will have a high fever, which often will increase suddenly. They will often complain of a headache, chills, pain located posterior to the pinna, and they may even experience discharge from the external auditory canal of the affected side. With physical examination, the clinician will possibly note swelling of the mastoid process with associated redness. The swelling may be so severe that it actually can cause the ear to protrude and stick out more than the unaffected ear. The clinician may also note fluctuance with palpation over the mastoid process. The area will likely be exquisitely tender. Now, these pictures show examples of what you may see on physical exam. If a patient presents with a chief complaint of ear pain and redness or swelling posterior to the ear is seen, as in these pictures, mastoiditis should immediately move to the top of your differential diagnosis. Mastoiditis is largely a clinical diagnosis, which means it is usually accurately diagnosed based on the patient's history, as well as their signs or symptoms. Recent diagnosis and possible treatment for acute otitis media is also a strong predictor and should increase your suspicion for the diagnosis of mastoiditis. As I said earlier, inadequate treatment for acute otitis media is the main precursor to mastoiditis. If the diagnosis is uncertain, or the clinician would like to confirm his or her diagnosis, a CT scan or plain film X-ray can be ordered. Now, plain film X-rays are rarely needed or used for that matter. However, if needed to confirm the diagnosis, radiographs may show what we call a coalescence of the mastoid air cells, which means they're joining together. This occurs because the infection causes the destruction of the bony septum that is normally between the individual mastoid air cell pockets. A CT scan of the skull can also be used and is more often the imaging modality of choice. Now, CT scan has the added advantage of providing detailed images that may reveal spread of the infection through the mastoid air cells and into the cranium. As you can see here, these are CT images that show inflammation and infection of the mastoid air cells. Just as I mentioned, untreated mastoiditis may spread through the temporal bone and into the cranium. Meningitis and epidural abscess and other brain abscesses are possible complications of mastoiditis and are very serious and extremely potentially fatal. Obviously, the best course of action in treating mastoiditis is to prevent the condition in the first place. Adequate treatment of acute otitis media with the appropriate antibiotic and dosing schedule is very important. In the case that mastoiditis does develop, however, and the diagnosis has been established, the patient should be started on IV antibiotic therapy as soon as possible. A MYRINGOTOmy needs to be performed as well for culture and drainage. I'll talk more about the MYRINGOTOmy procedure in a moment. The Sanford Guide to Antimicrobial Therapy recommends empiric treatment with IV cefotaxime or ceftriaxone until culture results are available. Culture results can take up to 48 hours or more. If culture results are positive for Staph aureus, it could also be very appropriate to change the antibiotic therapy to vancomycin or nafcillin. Now let's talk about the MYRINGOTOmy procedure. A MYRINGOTOmy is a relatively simple procedure, most often performed by an ENT physician. A small incision is placed into the tympanic membrane, which relieves pressure and allows drainage of the purulent material in the middle ear. A sample of the purulent fluid is collected, which is then cultured in the lab to identify the causative microorganism. Obtaining a culture and sensitivity is important because it allows for adequate antibiotic treatment to be achieved. Often a MYRINGOTOmy is concluded by insertion of what we call a tympanostomy tube into the tympanic membrane to facilitate continued drainage and pressure relief. If medical management by IV antibiotic therapy fails, surgical drainage and removal of the mastoid air cells is indicated. This surgical procedure is called a mastoidectomy and is basically considered a measure of last resort for mastoiditis. Something very important to remember when treating a patient with mastoiditis is that meningitis and intracranial formation are very serious complications that can develop. Clinicians should always be on the lookout for signs and symptoms that may indicate intracranial involvement. The successful treatment of mastoiditis requires close follow-up and prompt consultation with specialists. It should be a team effort. As always, don't forget to treat your patients with all the decency and compassion that they deserve. Every patient deserves a caring medical provider, and the patient's needs must be our main priority. Thank you for watching my presentation on mastoiditis today. I hope that you found it to be enjoyable and educational. Please subscribe to my channel to see my other video presentations. I'll try to add many more in the future. I hope you have a great day. Thanks.